Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.
All right, welcome back to Pod Patrol with your host, Dr. Jeff Dikis.
And Dr. Leland Jaffe.
On this episode of Pod Patrol, we're going to jump into some financial and contract discussions. And then later, we're going to spin the wheel of destiny and find out what we're going to debate today on our topic. We took the gloves off last time and really let them fly. So hopefully this time we have another good debate. How you doing, Leland?
Good. How was your week?
Doing well, plugging along, staying busy.
Yeah, absolutely. Absolutely. Same here. Likewise. We had a good week at our school. We had students on spring break in February. So it's kind of an odd week without students. I know. I saw that face. I kind of had the same one when I looked and saw that we had spring break in February, kind of a weird schedule.
What's the reasoning for that?
Just kind of falls into the quarter system in terms of
makes sense.
Yeah, in between. So yeah. So things are good.
Good, staying busy. Yeah, I'm seeing so many patients. It feels like schedules go in waves. I don't know if you feel like your schedule does that, where there'll be certain times of the year where I'm insanely busy, and I'll think, oh man, I'm drowning here. I can't keep up. Then it'll kind of wane, and then I'm like, oh, this isn't so bad. Where are all the patients at? And then as soon as I start thinking that, whoop, goes right back to the other way. So I don't know. Do you find
it's funny, I came from a private practice setting in St. Louis, like we talked a little bit about before, and I definitely felt the waves a little bit more in a private practice, especially once we hit that new year and deductibles kicked in again and insurance plans maybe paused a little bit of patients' eagerness to go see the doctor. Most of the patients I see now, most of it's non-elective, hospital-based. A lot of infections, a lot of wounds, a lot of things that, really don't necessarily.
They don't get to pick when
not
they
exactly
see the doctor.
Right. I see as many of those waves as I did before, nevertheless.
Sure. So we're going to jump in here and start talking about some finances. So I think you and I will be able to provide some amount of expertise on the financial side of things, maybe something that most people don't necessarily want to talk about, a little bit taboo in terms of what's your salary, what's the expectation. But I think a lot of students, especially residents, as they get closer to those first jobs, are very curious. If they get handed a contract for $125,000 as a base with a bonus structure that kicks in at twice your base salary, and you get 40% at twice your base, they start thinking, what's going on? What does that mean? How much money am I going to make? And I think at the end of the day, with contracts like that, you don't know how busy you're going to be. Well, you might be making your base. You might be sold a product where they say, hey, doesn't this sound so good? And you jump in, and all of a sudden, well, the volume isn't what you thought, and you're going to be making only that base salary. So I think there's a lot of muddiness to the waters from a contract standpoint, and typically contracts are going to favor the employer, right? It's like when you go and buy a car, they're not going to bring you a deal where they lose money. They're going to bring you a deal that if you take it, they're in the back high-fiving thinking, hey, look how much, I'm going to Outback Steakhouse on me tonight, guys. Like we're going big, right? Like,
I like that.
They sold a car. That's the best we have here. Actually, we just got Ruth Chris, so that was
there you go. That's an upgrade.
Yeah.
It's interesting. I mean, finances is really never introduced into any curriculum that I've been a part of, whether high school, undergraduate, even into podiatric medical school. Also, I mean, we did have some practice management courses, but never really strategies to be financially savvy and really thinking about retirement long term. You're at that stage when you're 20s, low 30s, you're like, retirement, when is that? And am I ever going to be able to do that? But it certainly comes quicker than I think a lot of people realize. And it should be in your crosshairs right from the get-go in terms of how to strategize.
Absolutely. You're going to be an advantage if you know these things. It's like same going back to that analogy. If you know everything about the car and what the same car down the street costs, you're an advantage compared to not knowing any of that information. So being informed provides you the armamentarium or whatever you want to call it to be able to make good decisions for yourself. And if you don't have that information, well, maybe it'll be okay, but maybe you get taken advantage of, or maybe you get locked into a contract that 2 years down the road you realize, I shouldn't have signed this isn't in my best interest, but it sounded good at the time, or maybe you didn't know any better. So
yeah, I mean, they always say the money invested earlier on in your life are going to be the most valuable dollars. And so missing out on those opportunities early on can definitely hurt you long term, which I know is something hopefully we'll be able to talk about here. But understanding those strategies early on is so important.
You're already at a disadvantage being a physician. No one's going to weep for you. No one's going to, play the little violin on their shoulder for you as a physician from a financial standpoint. But you are at a disadvantage when you're starting out because you're delaying the time until your first paycheck, your first real paycheck. You jump from undergrad and your friends are diving into a real job where they're making a salary. Yeah, you could argue your salary is going to be higher in the future and justify that later. But you are at a little bit of a disadvantage in terms of those early investing years, like you said, because compound interest is so powerful. The earlier you start investing, the better that is in the long run.
Absolutely. Yeah, there's a couple resources that I've read about online called the money multiplier, which basically looks at if you invest $1 at age 20, 30, 40, 50, how much does that have the potential to turn into when you eventually hit retirement? And it really drops off precipitously the longer you wait. So definitely an interesting topic to discuss. Yeah.
And it gets very complicated too, because these are your dollars to invest. And if you invest them wisely, they will do well for you. And if you do not invest them wisely, Bitcoin, Ethereum, cryptocurrency, people made a lot of money on that, but there's a lot of people who lost a lot of money, right? So investing things wisely is only going to benefit you in the future. So knowing all this stuff up front is helpful. Physician finances, salary, loans, investments. So the things that you need to know as a student, a resident, and even an attending. I've been around some people who are getting closer to retirement age and have not done the necessary research to make sure that they have put themselves into a position that makes retirement as enjoyable as you think that it should. We'll put it that way. Have you experienced that or found any of that to be true, both in medicine or outside of medicine?
Definitely. I mean, I wouldn't say I have as many colleagues approaching retirement that aren't prepared for it, but there's a lot of constituents my age, in their 40s now that are likely well behind where they should be. That's kind of more what I see is really not having a plan, not having a strategy at this stage of our life to be able to look at the next step in terms of how to be successful, approaching retirement. And, I'll be the first to admit it. When I graduated from residency and I got my first job outside of residency, I had no idea the difference between a Roth investment, a traditional IRA. What should I be doing? Should I do any of these? Should I knock out my loans first? I had no roadmap in terms of what I should be doing with these dollars. So it did take a number of years before I really had a good financial literacy to come up with a plan to not only get out of debt, but to try to build, that proverbial nest egg, if you will, for the family.
Yeah, for sure. Because like we talked about, the sooner you can figure these things out, the better it is for you in the long run. Because a lot of times, once you figure these things out, you can almost set it and forget it. Once you find a financial plan that works for you, I think some people are intimidated. Oh, I'm going to constantly be having to move money and reinvest and tax loss harvest and convert money to a backdoor Roth IRA. And yeah, you can do all those things, but those are the people who know what they're doing. Those are the things that are a little more expert level. But if you can jump in on just a kind of a basic level and do the right things, it's almost a set it and forget it, especially with a retirement plan with your employer. So I sit on the investment board for my group. So we help kind of formulate the investment plan for all the physicians and ensure that we're on the right path. We do work with an outside company that helps guide us, and those services are available to the physicians from a financial planning standpoint. but we do have physicians that sit on the board and help guide those investment options to make sure that, you know, people aren't being taken advantage of and that they're on the right track. So
Sure. I mean, I work for a big institution, and so it's you know, we have obviously our HR department and the whole retirement section of that. And you'd be surprised though, you still have a lot of control of how much you contribute, the percentage of your salary that you're withdrawing to be able to contribute to retirement. So you do have more control than you think.
yeah, what percent goes to Roth investment versus regular?
Exactly right. You know, and again, these are probably ongoing thoughts and discussions you should be having with your family in terms of how you're doing each year. One thing that our family does every single year is a end of year snapshot of our net worth, if you will, kind of looking at what we owe, what we own, what are our goals for the next year. Really just kind of sitting down and just having our finger on the pulse of how we're doing this year, and really making goals for next year. I think if you just don't have a plan or a strategy, that's where you can really start to flail and not make much progress or traction.
There's really only two people that shouldn't know what's going on with their investments, and that's the people that don't have enough money to invest and the people that are so stinking rich that they don't care what's going on with their investments, right? Everyone else should have a good grasp of where their money is, what it's doing, what it's earning, and if it could be somewhere better. So let's jump into salary. I pulled this chart from US News and World Report that kind of talks about the bell curve of a podiatrist salary. I don't know that their salary figures are all that accurate, but they did list podiatry as one of the top 10 paying jobs in America. They list the real meat of the curve there from 97,000 to 210,000, which, you know, is a big range there. If you're making 210, maybe you think, wow, I'm doing great. I've got a beautiful house. I'm driving a nice car. If you're making 98,000, maybe you're struggling to pay your loans and your mortgage, and depends on, you know, are you in what they call an HCOL, high cost of living area?
Yeah, definitely the Cook County area, we're faced with that. So no doubt about it.
Yeah, it depends on where you live. I used to live in one of the lowest cost of living areas in the country in East Tennessee. It was consistently listed one of the lowest cost of living. There was no state income tax. Property taxes were next to nothing. So Tennessee is a high tourism population state. So they rely on a lot of tourism dollars. People coming to the Smoky Mountains, which before I moved there, I had no idea was the most visited national park in America. I would have said
myself.
Yeah, it's beautiful. It's worth a visit. But I would have definitely said, you know, Yellowstone or I don't know, Grand Canyon, something else, not Smoky Mountains. But anyways, they have a lot of tourists coming there that offset all those costs. So the people that live in Tennessee, they pay extremely low taxes. Now, if you live in New York City, LA, Chicago, that your $200,000 in Iowa is going to go a lot further than my $200,000 in San Francisco. It's just factual, right? And you have to factor that in when you're looking at salaries and comparing contracts and all of those things. You can't compare apples to apples. If you got a job in New York City and you got a job offer in, you know, the middle of Nebraska, those two things are going to be very different in terms of cost of living and tax structures and all of those things. So I thought that maybe a reasonable level for a podiatrist was about 125 to 600. When I first got out of residency, I received a contract offer for $90,000. And I looked at it and it took me 5 seconds to say no. I did not go to 4 years of school and then 3 years of surgical residency to make $90,000. It's just not going to happen. I'm not doing it. Right. And so, but they probably will find someone who will take that job. At the end of the day, they're going to pay an amount that they can get someone to work for. And if they can hire that person and they will work for $90,000, all of the money over and above the $90,000 going into the pocket of whoever hired them, whether it be a hospital system, a private practice, an orthopedic group. So you have to keep that in mind. But you also don't know your worth, right? If I asked you, hey, you're coming out of residency, how much should I pay you? Do you know?
Absolutely not.
Right. That's the problem.
Yeah, I think so. I think coming from a resident salary, everything looks like a significant upgrade. But again, I think you can definitely undersell yourself if you really just don't know what your value is.
Yeah. And if you get locked into that contract, then it's going to be very difficult for you to go and ask for a raise, or at least a substantial raise. If you agree to get paid $90,000 and you find out your best friend from school got a contract for 150, and you go and you say, hey, I want to get paid 150, they're going to say, no, you signed a contract for 90, right? I'm not just going to give you free money. You signed this contract. You're in this deal now. So knowing your worth ahead of time is important. Now, you can't overvalue your worth either. You can't walk into some group and you have zero experience and say, I need $300,000. Maybe they'll pay you. I know some people that have done that. Those are rare. And at the end of the day, you need to justify that salary. You need to be bringing in dollars to be able to justify that dollar amount. You can't just sit there and be collecting 150 and they're paying you 300. Those dollars don't work. That doesn't make any sense.
Yeah, I think what you mentioned there that should be highlighted is experience. You know, I know a lot of practices are looking for somebody with some experience, and you know, I think it's okay to get one of those starting salaries for your first year or two with the potential for growth. You know, I know a lot of individuals, including myself and you, that, you know, pivoted away from our first jobs after a number of years. So, you know, that first job doesn't always have to be your dream job. But if it does get you experience and it does get you, you know, learning about contracts and negotiations and make you a little bit more savvy with those business skills, I think that there's value in that also.
I agree. And there's something to be said for finding that first job and then having something stable to pivot from, like you said.
Right.
There's a little bit of a rush and a little bit of not panic, but maybe a little panic for some people. They're inching towards the end of residency, and the closer they get towards the end of residency without a job, the more likely they are to just take something. Okay, I'll take it.
Right.
I'm moving my family. We're going to take it. I'm going to live here for a while. But then at least that gives you a job. It gives you something to be able to pivot. So my goal out of residency was to be able to come back to Iowa. For those who don't know, it's very difficult to find a good job in Iowa. We have the school here, and our population base is not that of Chicago, a big city, right? Those jobs were just not available when we were looking. So we did kind of come up against it and say, okay, well, we're just going to have to make this move, figure it out, make it work. And we'll talk about that later when we have Ashley on to kind of discuss a little deeper in terms of why we took those jobs and how we made that work. There was some component of just, okay, let me just take a job. We'll make this work for a while and then figure it out later.
Yeah. And I don't think there's anything wrong with that either. I think that's a good strategy for a lot of individuals. You know, because I think where I landed now is a perfect position for me and my goals and what I'm trying to accomplish professionally. But I don't think I would have been effective as an instructor without those 4 to 5 years of practice before, just to really learn about myself as a, you know, independent physician, learn about, you know, my strengths, my weaknesses, and really just grow outside of residency. It's really hard to go. I would not be able to be at the role where I'm at and be as effective as I am if I didn't have those, you know, those formative years ahead of time in the practice.
I agree, because you start to learn on the job a little bit. You can learn as much as you can in residency, but until you're actually out in practice and doing the coding and billing and seeing all those things, you start to get better at your job. Just like if you were learning to ride a bike, you get better at learning guitar, anything, you get better at it the more you do it. And with those years of experience, I think those are helpful, obviously. So when I came out of residency, I took a job in Tennessee with a base salary of $180,000. And the way that my contract worked was it was a 50-50 split, which means I got the 180, and then anything above and beyond that was a 50-50 split with the group. So if I brought in, you know, $1 million, well, I got an extra 500, well, minus the base salary, I got an extra half of $820,000, right? So, but that's bringing in $1 million. It sounds great on paper. You still have to bring in $1 million. Do I know people who bring in $1 million? Yes. It's very doable, but it is not very likely in your first job. When I pivoted to my current job, I took a quite a increase in my base pay, but the overhead is a different structure. It's more based on what your actual overhead is, right? When you pay your nurses, you pay the front desk staff, you pay the power bill, you pay your rent, you pay someone's got to shovel the driveway when it snows, someone's got to mow the grass, someone's got to, maintain the building, right? So all of those things are part of your overhead. And so I do make quite a bit more money at my current job than I did at my last job, but that's variable. And you have to factor in, okay, are you doing this for money? Or are you doing this to live in a place that you want to live? And maybe a little bit of both. So I think there's a lot of variability in terms of pay structure, that you may never know the right answer. You may never be hit with a dollar figure and be able to know, okay, this is fair. They do have some services that are will review your contract and make sure everything is on the up and up. But I've never heard of anyone reviewing salary. Have you ever heard of that?
No, it's more just how it's structured, how you're going to be reimbursed. Is it base salary? Is it RVU based? Is it, like you said, a percentage split based on what you bring into the practice?
When I first came out of residency, I made a document. I'll have to look it up and try to figure out how to post it. But I made a document that basically compared 2 job offers. And on paper, one sounded a lot better than the other. I don't remember the figures exactly, but it was something like the first job has a base salary of $150,000 with X% of bonus structure on top of that. And the second one has a base salary of $180,000 with a bonus structure. And it depended, each of those jobs could be better than the other one, but it depended on how much revenue you brought in. In one scenario, you'd have to make a significant amount of money to be better than the other job, even though it sounded better on paper. So I think they can throw these little loopholes at you and these little, contingencies of their contracts that sound pretty good, but then you get in there and you realize, wait, I'm going to have to see 80 patients a day to do what you made it sound like I was going to be able to do, no problem. That's not happening.
No, and that's definitely setting someone up for burnout, for loss of job satisfaction, having issues with family life. I think balancing personal and professional life. So I think you do need to be careful. And again, I think it is important to understand and recognize, what are your goals, right? What do you value? And is this in alignment with your values? I think that's important to be able to recognize.
Absolutely. I have heard some people who are constantly getting pestered by their employer. Oh, you came up short last month. You need to up your volumes. You need to increase your billings. You need to get your collections up. And first of all, that sounds like we're bordering on the immoral, if not illegal, if I'm just going to magically bump up my collections. That's not how it works.
No, I was going to say, what that makes me think of is I've worked at a number of different wound centers, and one of the wound centers I used to work at gave me a printout every month of how many patients I debrided, but also how many skin substitute products I used. And if I didn't use enough, they would ask me, Dr. X put skin substitute products on 50% of your patients, you only did 15, right? So why the discrepancy, right? And so things like that really make you, that are trying to push you or deviate from what you think is standard of care and appropriate for your patients, right? So that can become a very tricky situation to navigate if you feel like somebody is essentially dictating how you should care for your patients.
Yeah. Dr. X is going to get a Medicare go back and then spend a little time in the federal penitentiary, it sounds like.
No comment.
Yeah. All right. Let's jump ahead here. So salary negotiation. So we kind of talked about this a little bit, but your first contract's up in the air a little bit. Depends on your timing, where you want to be. Maybe you're willing to accept a lower salary to be closer to your family. Raise and renegotiate of the contract. I don't necessarily see that to be overly successful. Most of it is production based in what we do, meaning, you can maybe negotiate a little bit higher RVU contract payment, relative value unit. We can talk about how that works. I don't know that we're going to get into the weeds too much. You can kind of look some of this stuff up on your own, but RVU versus collection base is a big thing. But when you renegotiate, maybe you'll be able to renegotiate a little bit higher percentage of your amount of money that you keep, whether you have a base salary or whether you're on an RVU contract. But it's tough to renegotiate because you're going to have to justify why you're renegotiating. Why are you demanding more money? Why would we pay you more money?
Right. At that point, you're going to want to be data driven, right? You want to be able to demonstrate the value that you're bringing to this company and why you're deserving of that higher income, right? Instead of just, I've been here X amount of years, I've been loyal, I deserve more. Well, let's be analytical, let's be data driven, right? So you really want to try to bring those things to the table if you are going to renegotiate, just so that you can be very objective in your request.
One thing that people could use to their benefit, and I've seen it done, is to understand what your downstream revenue is. There is the amount that you collect based on your patient volumes. You see someone, you do an ingrown toenail, you bill X amount of dollars, you collect X amount of dollars based on cash pay, insurance, Medicare, whatever it may be. One thing that most people don't tend to keep track of is their downstream revenue. How many MRIs did you order? How many x-rays did you order? How many lab tests did you order? How many surgeries did you do while the patient was in the hospital? Those are all extra dollars that are not necessarily being attributed to you on paper, but are being collected because of you.
Yeah. And those are good negotiating tips for hospital-based physicians, because you're using MRIs. Your surgeries are usually outpatient, highly lucrative for the hospital. At our hospital, we use interventional radiology all the time. We do a vascular ultrasound and imaging almost on all of our patients, right? Which is keeping them busy. So you're absolutely right. I mean, there's definitely a lot of value outside of what you're billing, especially in the hospital setting.
Yeah, the hospital won't come to you and say, hey, yeah, you brought in this amount, but we're really happy because we got all this extra money because of you. They're not going to say that. So you need to be able to keep track. It's not a horrible idea to keep track of how many MRIs have you ordered? How many surgeries have you done? These downstream revenue that you'll probably never know the amount of money. How much money did the hospital collect on my, patient got admitted and I did a surgery and they stayed in the hospital for 2 or 3 days and got discharged? How much did the hospital make on that? You'll never know. So some of that is unknowable, but just keep that in mind when you're looking to renegotiate contracts, because there are some inherent benefits that you provide that aren't necessarily one specific dollar figure. Another thing that people can do is leverage one job for another. So what does that mean? I'm at a certain job. I want to get a raise. Maybe I'll look around and I will apply for other jobs and use that second job as leverage at my first job. This happens all the time. This happens in sports. This happens in, probably every place in America. It's not unique to physicians. I've never done this. I've never really heard of anyone doing this, but it is a technique to try to be able to renegotiate a salary increase.
Yeah, this is definitely a tactic that you have to be careful with, because you don't want to end up with no job. And so I think you have to be really strategic in how you approach this, if this is really what you're looking to do. And before I would leverage one job for another, I really want to be sure that I can move towards a different job. Because once you leverage your current employer, it creates a weird dynamic between you and your employer, right? And
Absolutely.
and that's going to be something that could linger long term. So I think if you have intentions on staying at your current job, leveraging or threatening to leave is probably going to leave a awkwardness at the least between you and your employer.
Well, it's also going to plant the seed in your employer's head that you're looking to leave. They didn't think that was on the table. Now all of a sudden it's on the table. Well, we better start gathering some applicant profiles. I just had a guy stop in yesterday and he laid down his CV on my desk and said, hey, I want to work here. Now the wheels start turning. Okay, well, if this guy's looking to leave, maybe we'll let him leave.
Right.
Or her.
Right.
Right. So the last thing on the slide is ancillary income. There are some extra ways that you can boost your salary. Two of the ways that are probably the most common would be investing in a surgery center. Most surgery centers, in fact, it may be a law that you can only invest in surgery centers that you are a part of and that you actively bring cases to. You can't just go around and start buying shares in surgery centers. Can't do that. So it has to be somewhere local and somewhere that you bring cases, usually at least 1/3 of your Medicare cases and 1/3 of your surgical collections have to be performed, of eligible cases, have to be performed at the surgery center in order to justify your partnership with the surgery center. But that would be one way to
Yeah.
obtain some ancillary income.
Yeah. I got approached about this when I was working in Missouri.
Mm-hmm.
And it was a difficult decision because at the time, this was probably when I was a couple years into practice, and I really had very little expendable income. I had two
Sure.
young children, and so to buy into a surgery center at that time really was a risk I personally wasn't willing to take. Was that a bad decision? I really don't know long term, but there's definitely a lot of individuals I know that get a nice check monthly from a surgery center just from the shares that they own of that center. So it definitely can be lucrative in the right scenario. But again, the decision is in order to get those, there's a buy-in, and that buy-in is usually somewhat substantial for most of us.
Yeah, you made the right decision because you're no longer at that job. So you would have been looking to try to get out of the surgery center, right? Which
Sure.
sometimes they are on the up and up and they'll just give you the money back for your share volume. And sometimes I've heard of many things going south where the surgery center isn't doing well and they don't have liquid finances to be able to pay someone to get out of the surgery center. This is something you need to be a little careful with because not all surgery centers are created equal. I have heard of surgery centers going out of business. So if they go out of business, where did your share of your money go? It's gone. You don't get that back. And your revenue stream dried up. So vetting the surgery center, maybe working there first before you invest and getting a lay of the land would be a good decision.
You should be able to get a general estimate of, if I own a half a share, what would the typical monthly check be that I would expect? And then you can know, okay, it'll take X amount of months to get back my $15,000, if you will, whatever you invested. And then everything else is kind of gravy on top, if you will.
And then the final is there is a mid-level provider, so a PA or a nurse practitioner. These vary by state law. In Iowa, you can work with a nurse practitioner, but you cannot oversee a physician assistant. Now they just changed the state law in Iowa, though, that now after 2 years, a physician assistant can practice independently. So they come out of school, they have 2 years of supervision with a MD or a DO, but then they can practice independently. So that's more similar to nurse practitioner. Down in Tennessee, when I was down there, podiatrists could oversee a PA. So they could have mid-level providers with them that were, depending on how busy they were, obviously boosting their ancillary income. If they're not busy enough, then it's a sunk cost. It's a lost investment. But as long as you're busy enough and they're justifying their cost, that's a good way to kind of boost your dollar level and lessen your burden, reduce some of your burnout because you're not having to see that same patient volume.
Absolutely. I've worked in a practice that had a PA, not when I was a resident, and it was incredibly helpful in terms of operating room assistance, rounding, post-op dressing changes, casting. It just kept things moving really, really nicely. So it was a huge benefit. But to your point, yeah, if you don't have the volume to support that, then yeah, that's going to be a cost each month that you're not excited to pay.
And I think there's two ways you can leverage a PA. One is to have them do those things that you don't necessarily want to do or that don't bring in money, the post-ops, the rounding, the dressing changes, because then that frees your time up to see the things that are revenue generating. So when you get your statement at the end of the month from that, it's not going to look like they're paying for themselves, but you have to realize that is allowing you to then spend more time doing things that are revenue generating. The second way you can do it would be to have them function almost independently, see their own schedule. And in that way, they are going to generate more revenue and allow you to spend more time seeing some other things because you can kind of pick and choose which things that remain on your schedule and which things don't.
Sure.
The next slide says, does my training matter? And does fellowship increase my salary? So does my training matter? What do you think? Do you think training matters when you get out into the real world in terms of finding a job, salary, what you're worth? Do you think whether you went to program A or program B, you're going to drive the cost of your salary up in any way?
So it's a simple statement, but it's a lot to unpack. Because I don't know if it's a simple yes, no answer. I think it's a little bit more nuanced, in my opinion, because Right. If you go to a brand name residency, it might not necessarily from day one demand a higher base salary, but over the course of your career, if you have better training, I think that will definitely directly impact your trajectory throughout your career in terms of your earning potential. So you might not be able to leverage that higher salary on day one at your first job if you want to a brand name program versus one that's not as well known nationally. But again, I think I always say, if you get the best training possible, because if you have better training, it will definitely positively impact your earning potential throughout your career. I've no doubt about that.
I agree with that. I don't think if there's two applicants that they're looking that closely and saying, oh, you went here and the other guy went there. Oh, that means we're going to hire you and we're going to give you all this extra money. I don't think that's happening. But I think you do have to factor in, like you said, the better your training, the more variety of surgery and technical skills you may have, which open you up. And if you are doing some things that are more technically demanding or that not everyone can do, then you are going to justify a higher cost or a higher salary or be able to collect more based on those higher level of technical skills.
Absolutely. And I think not only will your technical skills and the services that you could provide going to be much greater, I think the more training you have and the more connections you've made through your residency, I think the more opportunity for some of these other ancillary income streams like consulting, working with orthopedic groups, doing working with courses, ACFAS courses or other there's other revenue streams outside of your primary job. And I think the better your training, the more you can command for those types of roles.
Yeah, I think that's reasonable. When I was looking at residencies, I had considered, or I thought that, going to University of Pittsburgh would carry some weight in the orthopedic world. It's a top 10 orthopedic residency in the country. And in my mind, one of the better podiatry residencies. But I don't know that that was necessarily the case. I don't know that I, applied to so many ortho groups and that they really cared. They care more. It's kind of like how I viewed the students. Oh, I'm number one in my class. Like, I don't care. I want to meet you. Do I like you? Are you nice? Are your patients going to like you? I don't care about all that stuff. I have to work with you every day. I want to meet you. I want to know you. I care more about that than anything on paper.
I 100% agree. And I talk to a lot of residency directors or clerkship directors, people that interact with students all the time in the clinical setting. And they will often say, like, we'll have a 3.0 student outperform a 4.0 student on clerkships regularly, right? So, it really does. You can't just solely rely on an item line on your CV to really carry you. You really have to be able to support that with, like you said, those interpersonal skills, your work ethic, your bedside manner, your likability, right? All those things that can't be measured necessarily do play a big role. And what we can get into practice management probably at another episode, but the more your patients like you, the more they're probably going to send people to see you.
Yeah.
Also, the more your patients like you, the less likely you are to have any litigious issues. And I mean, there's a whole host of benefits by just having that likability, especially with your patients.
I mean, I hear it all the time. I never, ever, ever once have heard a patient say, oh, you went to the University of Pittsburgh. That makes you a great doctor. They say, he was so nice, right? When you go to the doctor, was he great? Yeah, he's so nice, right?
Yeah, he spoke in terms I understood. He took his time with me. He showed that he really cared about my well-being. He personally called me with the lab results as opposed to having someone else do it. Like, it's just these little things that don't take a lot of effort, I think, make a huge difference.
Yeah, for sure. And the second one here says, does fellowship increase my salary? I would say no, with one caveat. And that goes back to the training. If you expand your horizons and you gain technical skills that you wouldn't have otherwise had from your residency, and you gather these additional skills, then the answer is yes. I don't think that a group is going to come along and say, oh, you did fellowship, oh, well, then you get to start at this salary. I don't think that's going to happen.
Yeah.
But if you start at a certain salary and then you're doing these additional things that the fellowship provided you additional training in, again, maybe those are some higher earning, higher compensated technical skills that were worth the justification of the fellowship, because there is a cost, there is a sunk cost there, right? When you go to fellowship, there's less of a salary compared to maybe your first job salary. So you are taking a bit of a hit there. So I'm not against fellowship in any way. I'm just saying there's a lot to figure out here if it makes sense for you, not just say, oh, I want to do a fellowship.
Yeah. I agree with everything you said. The only thing I'll add to it is, at least again, I work in the Chicagoland area, and I do see quite a few job postings that would say fellowship trained podiatric surgeon is what they're looking for. So it does, whether or not it increases your training or increases your skill set, which hopefully you're doing that year to improve those skills and to really develop that niche. But it does make you more marketable. Right.
I think that's
there's
reasonable.
probably no way to dispute that. And, I always say I'm jealous when the ACFAS fellowship breakfast, and I love how they put it at 6:30 a.m. on Saturday to really make sure you're committed to fellowship, knowing that everyone gets taken out on a Friday night, and they're really trying to see, can you get there at 6:30 a.m. on Saturday?
Interesting.
But there's 50, 60 plus fellowships, maybe more now. I can't count them all, but I mean, the opportunities to obtain that advanced training now is better than it's ever been. And it seems like it's not slowing down. So
I think we should spend maybe an entire episode talking about fellowships, because we could take a deep dive into that.
Oh, so absolutely.
Let's leave that part there, and we'll come back in a future episode and talk about fellowships, because I think that's interesting in the shifting dynamics of our profession, because orthopedics has been doing fellowship. I mean, you're not going to find any orthopedic resident that doesn't do a fellowship anymore, right? It's just unheard of. So I think that's an interesting shift in the dynamics. Yeah, right. Exactly. So I think we should come back to that in a future episode. And maybe we need to come back to this because all of these probably deserve their own episode.
Yeah, I agree.
But this on the surface says, when should I repay my loans? And now that I'm looking at this, I think maybe we should save this for a future episode and talk about student loans and repayment and all those things. What do you think about that?
Yeah, I mean, I think we can just have a couple big, broad statements on this, though. Just making sure that when you graduate, you have an awareness of what loans you have, because sometimes you don't even know, because your larger loan can be broken up into subsidized, unsubsidized, federal, private. Really just getting an awareness of what you have and what you're bringing in, and having a plan, right? So that you're not, again, flailing with, you really want to know that where's every dollar, make sure that every dollar you bring in has intentionality in terms of how you're spending it. Right. And I think just having a good awareness of that is important. I think a lot of people that I know of don't necessarily have a good appreciation of what they owe and have any plan and goals. Right. So it should be something that you're revisiting frequently so that you can stay on track and see if you're meeting your goals, if you're not. And if you're not, how can you reshift the deck a little bit to try to meet some of those objectives?
I think the biggest takeaway from this slide should be understand compounding interest. And so when you're a student, you take out loans, every meal you go out to, every dollar you spend on rent, every car payment dollar, because that is all the money you're living on. Every dollar you are spending is not $1. It's $1 plus 6% plus another 6% compounded annually until you pay that dollar off, right? So it sounds great. Oh, I've got all my money came in. Let's go. I'm not saying don't live a little. That's not what I'm saying at all. And I certainly did. I spent more money than I probably should have. We lived in a nice condo in Pittsburgh and went out to lots of nice meals and had fun. But that money can add up quickly.
Yeah, I think that's a good point. And the opportunity cost for that is paying down your debt and or investing at in your mid-20s. Because again, if you invest $1 at 25 in like the S&P 500 or just some index fund, then that $1 by the time you're 65 is probably going to be somewhere like $65. It'll turn over that many times. So the opportunity cost of not having a plan at that earlier age could have detrimental effects downstream. And I'm guilty of that too. Again, I didn't know these things at that age as well. So, I guess that's why we're doing this.
Yeah, I think we'll circle back again for
yeah, lot to unpack there.
I think there's a lot there. And then high income investing. So I think the biggest takeaways from all of this would be to create a financial plan. If you don't know what that means, I highly recommend a place called White Coat Investor. White Coat Investor was started by an emergency room doctor in Utah and has grown this company to entail all components of investing, but it's physicians leading physicians. And the benefit of that is that you don't want to necessarily take advice from just anybody, especially a financial planner that may or may not have your best interest in mind. When they see a physician income, they will jump at that opportunity. We had people come to present to us in residency and we didn't know any different. Oh yeah, they sound great. Okay, well, here, let us manage your money. All of a sudden they're taking a little piece of it. Like you said, with compounding interest, they take a little. Well, that little for me could have turned into a lot in the future. And I didn't necessarily need them to do that. So White Coat Investor is a good financial resource for physicians. Highly recommended.
Any good podcasts you listen to, financial wise?
Well, White Coat Investor does have a podcast. They have on lots of different guests in terms of, different physicians who have done well to repay their student loans from that standpoint, and financial planners who they've vetted to be, better than the average. But other than that, not necessarily. I think over the years I've been bombarded with all this information and I feel like I kind of understand it pretty well. Anything you listen to?
Yeah, one of my favorite ones is called The Money Guy.
Okay.
But these are two financial planners that one of them is actually a public accountant as well too, and they work out of Nashville, but their approach is very straightforward, but also I think gives you a good roadmap of how to strategically use each dollar. And so that's one that I like listening to, and I think they give a lot of good sound advice.
Give us the name again.
It's called The Money Guy.
The Money Guy podcast. Okay, good to look into. And then some other basic financial tenets here. Knowing the difference between index funds and mutual funds. Obviously, mutual funds are actively managed. Index funds have much lower fees. Again, I'm not going to get into the details of these, but if you don't know what we're talking about, then you're the type of person who needs to dig a little deeper, because these are fairly basic concepts. At the end of the day, you can't necessarily go wrong with what's called a target date fund. Target date fund, at least if you pick Vanguard or some low cost investment vehicles, target date funds are a very reasonable thing. So what they do is they pick your intended target date for retirement, whatever that may be, depends on how old you are. And then it will structure your investments and broadly invest them across diverse types of funds, right? So if one fund goes down, you're not sunk, all of your costs are not sunk. That's what diversity means. And then it will automatically adjust those as you get closer to your retirement date to make them less and less aggressive, less risky. You don't want to be 2 years from retirement, all of a sudden the stock market crashes, you have no money. Well, the target date fund, as you get closer to retirement, will alter your investments to be less risky, more bonds, less cryptocurrency, right? And be more of a stable income as you get closer to retirement. So when in doubt, if you can pick a target date fund, you pretty much can't go wrong with that in my mind.
Super easy. All you need to figure out is when do you need the money and how much are you willing to invest?
Yeah,
and then you set it and forget it.
Exactly. So I think that wraps up some components of salary and contracts and loans and investing. I think we'll circle back to some of those topics on future episodes because there's a lot there to unpack.
Perfect.
So let's move on to the next part of the podcast, and we are going to spin the wheel of destiny. What do you think, Leland? Is it going to go in your favor? Last week, I don't know, you had to defend MIS head procedures. I don't know, that was tough.
No, that's an easy win.
I don't know about that. All right, let's spin the wheel of destiny here. We got lots of things here on the wheel for us to debate. Let's see what we get this week. What if we get the same one? We have to throw those old ones out. All right, what do we have? MPJ fusion versus implant. So last week I got to pick, right? Last week I got to pick Lapidus. So that wasn't necessarily fair for you. So this week you get to pick.
Yeah. I mean, I could go the difficult route, but I'm going to take the easy road out and take the fusion here. Maybe that
puts me in a tricky spot. That puts me in a tricky spot here, but I'm going to defend implants, first MPJ implants. So why don't you go first?
Yeah. All right. Well, where do we start? So much to unpack here, but it's funny. I've been going to conferences for, gosh, I don't know, 2008. So 14, 16 years now. And it seems
You're
like
getting old. You're getting really old.
I know. I'm doing the math.
Carry the one. Wow. Okay.
No, but I feel like first MPJ pathology is something that's debated a lot on stage. It's definitely something where there's not necessarily a general consensus on how to treat these particular conditions. So, it definitely is something good to talk about. Fusion. Why is fusion a better surgery? Well, I think the obvious answer is it's predictable in terms of your short and your long-term outcomes. I think if I'm trying to talk to patients about expected outcomes, then I think managing patients' expectations is probably one of the most important parts of doing your preoperative assessment and education with your patients. And I feel
for any surgery,
and I feel with a fusion, I can't guarantee many things in life, but I can usually guarantee that your toes gonna be a lot straighter. It's not going to move and it's not going to be painful. So yeah. I feel pretty darn confident after having that conversation with them. When I put an implant in, or if I'm recommending an implant, I'm just nervous. I'm always trained, as everyone else is, when you put something in, you need to have the idea of, okay, how am I going to take it out? And if I have to take it out, what do I do then? Right. And so that makes me a little bit nervous about resecting joints and doing some types of interpositional arthroplasty type procedures. So, yeah.
So on the flip side of that, we've got implants. I think originally implants, when we're talking implants, we're talking first metatarsophalangeal joints. So the big toe joint implants, we're talking about either fusing the toe into proper alignment and leaving it there, or replacing it, like when someone gets a new knee or a new hip. Very different in terms of the constructs, but the idea is the same in that you're retaining motion. Originally, a lot of the implants that were silicone, the Swanson implants back in the 60s and 70s, had a high failure rate. And I think just like anything, when you have a new product that has a high failure rate, it turns off a lot of people. They hear implant and they think, nope, those all fail? Well, just like anything, the original total ankles were not as good as the current total ankles, both in terms of planning and construct and materials and all of those things. So with time, you can infer that the construct has improved, the materials have improved. We've made, significant advancements in terms of simulating the modulus of elasticity of bone and making the overall product better. So in my mind, if you're able to retain motion at a joint, why wouldn't you retain motion, right? You can use the MPJ fusion as a bailout procedure, and we've all done that, I'm sure. If you get far enough into practice, you see every little, gadget and gizmo that someone has stuck into someone's foot over the years. Oh, we used to do this. Well, now I got to take it back out, man. Like, don't do that. Don't put that in there. But, you can use the fusion as a bailout plan. And there are a few specific people that I would really skew more towards implant than fusion. And those would be certain laborers, plumbers, electricians, people who have to kneel. When I talk to them about fusing their big toe, they say, will I be able to kneel? And I say, well, yeah, with your left foot, you got to learn to reverse your kneel, right? But maybe they're using a toe kicker for carpet installation or hardwood, or a plumber, electrician. There's a lot of skilled laborers that require maintained motion of the first MPJ, and those people would certainly benefit from an implant versus an MPJ fusion.
So when I'm thinking about arthroplasty versus fusion, I always go back to I don't know if it was a paper or a textbook, but I think it was Dr. Sig Hansen talked about joints that are essential and non-essential, or they categorize some joints as being useful, right? So
I was hoping you weren't going to bring this up.
So,
I was thinking the same thing. I was hoping you weren't going to bring it up.
When we talk about essential joints, what are we talking about? The ankle joint, right? If you fuse the ankle, there are definite biomechanical sequelae that can happen. If you fuse the talonavicular joint, another essential joint, we know there's going to be altered motion at adjacent joints, which can cause adjacent joint arthritis and other complications. Even lesser MP joints are considered essential. So the second, third metatarsophalangeal joints, those are joints that traditionally are not fused. The first MPJ, to many people's surprise, is actually not categorized as an essential joint. So you can fuse that and really not lose much, if any, biomechanical function of your foot. And I have a lot of patients that fuse their first MP joint and are still out there running and being very active in athletics and sports, and function quite well. Usually, what I tell patients is, if I'm going to fuse your first MP joint, you might struggle with yoga or exercises like that. Certainly, you can't wear a certain height of a heel, and you can't pick pencils off the ground with your great toe anymore. Other than that, you're going to be pretty A-okay, I think.
So, I mean, I think it's important to, understand the difference for essential and non-essential joints. But at the end of the day, sometimes I do have a difficult decision with people telling them that they need a first MPJ fusion and them not quite understanding how will that affect my mobility, how will that affect my my function, even if they're not any of those jobs that I had mentioned previously, if they're just worried, like, well, won't that, alter my function? So sometimes, you get led down a path where people are more hesitant to undergo the fusion. And I think just like in any component of being a surgeon, the more technical skills that you have and knowing how to do more procedures, the better. And then you can kind of fine tune that and formulate that. I'm not saying that implants are the end all be all, but maybe it's reasonable to be able to know how to do those for a certain subsect of population that may be quite active or maybe quite young. Maybe they have a post-traumatic arthritis. They're not 70, they're 26 years old and they want to maintain their mobility and they're not quite ready for a fusion. I think then there are some components of implant that would be very reasonable, or even the cartilage resurfacing. Some of those have shown to not be very effective long term, right? And even total ankles are not something where you'll put it in a 40-year-old and say, yeah, you're good to go, you're never going to have a problem again. We don't tell them that. So knowing that, hey, if you have this procedure, it may maintain some motion and you may end up with a fused big toe joint 10 years down the road, maybe sooner, maybe longer, we don't know. But at least making them aware of their options and what the potential pitfalls of the procedure are if you're going to be doing an implant would be important.
And I think you bring up a good point. So whenever I put in an implant, I'm always thinking to myself, okay, if this fails, if it doesn't resolve their problem and it has to come out, how am I going to transfer this into a fusion? And so different implants, like you mentioned, the silastic implant, that has quite a bit of bone resection, both off the base of the proximal phalanx and the head of the first metatarsal. So if you take that out, you're going to have a fairly large void that needs to be filled with some type of autogenous bone graft or some kind of bone graft, right? The resurfacing definitely gives you a different approach, as if this fails, we still have reasonable bone stock available to convert that into a fusion. So I think no matter what you're doing, you have to think about, if this comes out, how do I convert that into the next step, right? So if it's an implant, how am I going to convert this into a fusion? And you really need to be aware of that. So I think that brings up a good point in terms of the resurfacing type procedures, if you're trying to maintain mobility.
So I think what we figured out is that it really depends on the patient. I mean, at the end of the day, if one of those procedures is more reproducible in a certain type of patient, then that's the thing that you should probably go with. If you've never done an implant, well, then maybe that's not a good time to try to figure it out on the 26-year-old with post-traumatic arthritis. Maybe, kick that on down the road. But being able to do each of these procedures would at least open up the opportunity to be able to discuss the options with those patients.
And again, manage expectations. Whether you fuse it, whether you implant it, you could have a great fusion, but if the patient really isn't aware that their big toe is never going to move again, they might hate that procedure. And vice versa with the implant. If you say that this is going to be perfect, your joint will move normal anatomically, you just don't know if that's true. And number two, you might have a perfectly seated implant on x-ray, but it still hurts. And so you just managing their expectations and making sure that those conversations are in your medical record is incredibly important. So make sure you don't skip out on that.
Now, in terms of the implants, I do tend to favor something more along the lines of a hemicap resurfacing on one side of it, but that would have to make sure that the other component, whether it's the base or the head, is still viable, right? I think that is a good initial kind of implant resurfacing type procedure versus the total bistem or bipolar implants. But I think some of the newer components are getting a little bit better, and there may be a day in the future where we look back on, well, why did you fuse the MPJ? Why didn't you just do this, right? And so keep an open mind, keep an open mind moving forward, and know that as things get better, maybe the outcomes change.
Have you ever done or considered doing an arthrodiastasis?
No.
Yeah, I've seen it. I more so for the ankle, where you're just distracting the ankle and trying to regenerate cartilage. But I've seen it also with distraction of the first MP joint with a mini rail external fixator and just distracting the joint, as opposed to...
I think the outcomes are pretty reasonable from what I've seen. To me, it feels a little gadgety. It feels a little bit like, what are you doing? Just do one of these. They work. Just go.
Yeah.
But I don't know. I think I'd have to see more information.
Yeah, and I just don't know what the outcomes would be. For me, it would be more of a... I couldn't comfortably tell the patient what to expect. That's why I've never really pulled the trigger on something like that.
Plus, nobody likes having a little mini rail, an X-fix, some pins sticking out of the toe, and infection risk, and it just feels a little unnecessary to me.
Making a simple problem a little more complicated. I agree.
Well, sure, yeah. So who won debate mate? Was it Dr. Jaffe or Dr. Leland? Leave your comments in the video below and let us know your thoughts on implants versus first MPJ fusion.
I should win just because of this bat above me right here.
Is that the bat signal?
Yeah.
When someone needs Batman, you come calling, huh? I haven't told people yet that I want to start calling us Jeffy and Jaffe. Welcome back to Pod Patrol with Jeffy and Jaffe. Yeah. We'll see if that catches on.
If my kids would hear that, I'd get accused of a dad joke, but I got no shame.
Yeah. But we are dads, so
that's true. That's all good.
Isn't that just self-fulfilling?
Yeah.
All right, let's spin into the next part of the podcast, which is case presentation.
So these are a couple cases I'm going to share with you all, and really just reflective of the topic that we're going through today in terms of handling first metatarsophalangeal joint pathology. So first case is a patient that presented to me with a painful first metatarsophalangeal joint, and when we look at this patient radiographically, and for those of you that are on audio only, we're looking at an AP view of the patient's right foot that had previous surgery done to correct a bunion. And so kind of an odd procedure that was done. It's almost like a silver bunionectomy with an Aiken.
With pins.
Not with pins. So not a very traditional approach to correcting a hallux valgus deformity, but nevertheless, that's what came in.
On the plus side, they only spent $55 on this patient. Terms of fixation.
That's right. So the hospital might see it as a plus, but
this is a win for them.
Unfortunately, the patient's still having problems, and the deformity is still there in terms of a hallux valgus deformity and all the radiographic complications that you see with hallux valgus. So talking to the patient here again, we had a couple choices. Anytime I have a patient comes in and the anatomy has been disrupted, because I know that first MP joint has already been dissected. The cartilage has already been stripped away and closed. Scar tissue is present. So I want something that's a one and done definitive. I don't want surgery number 3 for this patient. So I could consider doing something along the lines of a MIS bunion correction or a lapidus or something to correct the hallux valgus. So every time I would relocate this patient's first MP joint, it was painful. So I want something that's definitive, that's reproducible. So we talked about doing a first metatarsophalangeal joint fusion. So if we look at the next radiograph, we can see the lateral view as well too, showing very little sagittal plane deformity. But again, we can see the 2 K-wires in the patient's proximal phalanx. So
those look pretty buried too. Those are going to be real hard to get out of there.
Very hard to get out.
That when I evaluate the X-ray, I'm looking at hardware thinking, How much am I going to struggle to get that back out of there? This one looks hard.
It is hard. And, the question is, does it even need to come out?
Right.
So let's look forward to the next x-ray. And this is my post-operative film. So I decided to do a first metatarsophalangeal joint fusion. This is my initial non-weight bearing films on an AP and a lateral projection. And my construct for most of my fusions, I like to do some type of compression screw with a low profile plate dorsally. And there's a lot of different plates, so it's whatever suits you the best. But in this particular patient, I realigned the great toe joint and just did a fusion because I know there's not going to be surgery number 3 as long as we don't have any complications with this initial surgery. So if we look at the final x-rays that are weight bearing, this is our weight bearing x-rays. Again, I left the K-wires alone because I thought it was going to be more harm than good trying to dig those out. And fortunately, they weren't in they weren't in the way. And it's funny, a first metatarsophalangeal joint fusion has the power to really reduce your IM angle as well, too. When you eliminate that retrograde pressure on the great toe to the first metatarsal, and you keep that adductor hallucis muscle insertion intact, it really does help to pull that first ray laterally and close down that IM angle. So, we were able to really correct the bunion with a fusion, and patient's happy, painless. And again, you can really confidently say there's not going to be surgery 3. If I did a hallux valgus correction with any of the number of techniques that are available, I thought I can get that joint realigned most likely, but will it be pain-free? I don't know. And we weren't willing to take that risk. So we went on and did a fusion, and overall the patient was happy.
Yeah, I think that's very reasonable. It was Dr. Burns out of UPMC, my residency director, that looked at the IM angle reduction after first MPJ fusion and found that the adductor hallucis pull was actually quite strong in terms of converting the adductor hallucis from a deforming force as it comes transversely into the base of the proximal phalanx. You can picture it as a deforming force, but when you lock up the construct of the first MPJ, it becomes a reducing force of the IM angle. So keeping that in mind, that when I do a first MPJ fusion, I typically don't need to cut and translate or reduce or shift or do anything. I simply get it into optimal alignment. Number one, it usually falls into optimal alignment after you release all the soft tissue structures because you're going to get the cartilage off the head. You're releasing all the soft tissue structures circumferentially around the joint. So it's going to sit in better alignment. But then you know that you have that additional pull of the adductor hallucis that'll continue to provide a reducing force of the first intermetatarsal angle. I think that's a good takeaway point for that.
Yeah.
And second,
absolutely.
I would agree with you that leaving the hardware there was the right decision. Number one, you have to figure out why you're taking out the hardware. Is it prominent? Is it painful? Or is it just you think you're supposed to take it out? If it's buried in the bone and you can put screws around it, just leave it. You're going to cause way more damage and harm trying to get these pins out of there or certain screws. I've had to revise Austins before, and they have these stupid little cruciate heads of these little tiny screws or little snap-off screws or some kind of screw that they put in there. I put the little screwdriver on there and it just like snaps or bends or strips or something. And then you grab it with a rongeur and you're trying to twist it out of there and you're spending 45 minutes and you're like, all right, I'm just going to cut the head off and put the plate over top of it. Just make sure none of my screws in the plate align with where that is and just leave it.
Yeah. Again, it kind of falls back to when you put something in, you really want to have a plan to take it out. How are you going to have to take this out eventually if you need to? And with a cut off K-wire at the bone level, not going to happen.
Yeah,
so
it's not
case number 2.
Yeah,
case number 2, we have another case here. So this was a patient that had, again, first metatarsal phalangeal joint pain. On this x-ray, for those on the audio only, we're looking at an AP and a lateral projection of a weight-bearing skeletally mature patient. And all the findings of what you'd expect with a degenerative joint disease of the first MP joint, with asymmetrical joint narrowing, subchondral sclerotic changes, squaring off of the head. On the lateral, we have some elevatus of the first ray, as well as some dorsal osteophytes present. And so the decision-making for this patient was a little bit different. It's a primary procedure, not a revision procedure. And this particular patient was much more eager to retain motion of that first MP joint, like we just talked about in the previous segment.
So they agreed with me. Okay.
They did agree with you. So let's take a look at the initial x-rays here and see what I did. So So this is an AP non-weight bearing view. So this was one of the immediate post-op films of a hemi joint implant resurfacing the base of the proximal phalanx. So that's what I did. It's interesting. We talked a little bit about, and here's the lateral view too. You can see I did, and these are non-weight bearing films. So the hemi joint implant seats nicely into the proximal phalanx, and I resurfaced the head, or just essentially took down, almost did like a Valente cut or a chylectomy type cut on the metatarsal head to reduce the dorsal spur. So this particular patient did fairly well. However, when I put in implants, and I very rarely do anymore these days, I usually end up with about half of the range of motion as to what I had on the OR table. Scar tissue builds up, the things start to get a little bit more restricted. So it's never as good as it seems on the OR table. And so in this particular patient, I think earlier on in my career, I was more prone or susceptible to patients talking me into what surgeries I should do for them, as opposed to what's the best for them. So in this particular case, I mean, radiographically, it's acceptable, but let me tell you, the patient wasn't, if you were to grade their outcome, it would be fair to good. They were not thrilled, right? So I think in this particular patient, being a younger, active, middle-aged adult, probably would have fared better with, like you talked about, either a resurfacing type procedure initially, and then convert that into a fusion later on, or maybe just doing the primary fusion right away. So, it's funny, when you look at the first MP joint intraoperatively, very rarely do I see cartilaginous erosions from the phalanx. It's usually on the metatarsal head side, right? So, looking at this X-ray years later in terms of doing that hemi implant arthroplasty on the toe, it's almost, intuitively, it's like, shouldn't the implant be on the head? That's where the cartilage is denuded, right? So I think my approach to this would probably be much different now, years later, with a lot more experience under my belt, as opposed to earlier on. Not to badmouth the hemi joint implant enthusiasts out there, but my results with these have been unpredictable at best as to how are they going to fare, short, intermediate, long term.
I think it's difficult because hindsight's always 20/20, right? If you do this procedure and they do great, then it was a great procedure selection. If you do this procedure and they don't do great, then it was a horrible procedure selection. But you're basing that on patient outcomes, right? One patient may not be the same as the next, and the same as the next after that. So I think, understanding the data and the multi-center studies to get a large number of patient outcomes is important. But it's hard to beat yourself up too much, because at the time you select a procedure, you go with it, you're mutually agreeable with the patient. And just because it doesn't turn out perfect doesn't mean it necessarily wasn't the best procedure for that patient at that time, because you're going to be retroactively self-selecting and be critical of the ones that didn't turn out well.
I need more of that encouragement in my life.
Yeah.
I'm going to call you up next time I'm looking at an X-ray.
I'll come along with you. Come on, man. This looks good. What are we doing? This looks good. You did a good job. We just listen to the podcast. I'll record something and then you can listen to it in clinic. Like, come on, man. You're doing a great job.
That's right.
Yeah, keep going.
I need that.
Your patients love you. You're great. He was so nice. That's all you need to be, nice, and they'll love you.
That's right. It doesn't take a lot. But yeah, anyway, I think, not a inappropriate procedure. And again, the results were good to fair. But I think, being surgeons, we expect a lot out of ourselves, and, you want your patients to be perfect. And, those are cases where, if a patient is pushing me for that, I'm probably going to really have a conversation about what I think is the best for them, what I've seen the best outcomes in my hands. And, if you're really not seeing eye to eye with your patient in terms of what they're expecting and what you're willing to provide, I think it's always also healthy just to get a second opinion and see if somebody else can take a look and really put in their 2 cents about, what they think, and maybe they'll see better eye to eye.
We talked about that previously. I love second opinions. I don't know. It buys you some time too. It does 2 things. Yeah. It buys me some time, right? And I try to never schedule someone for surgery the first time I see them. It's very rare. Okay, aside from trauma, right? Trauma out the window, just ignore that. But reconstructive surgery, elective surgery, there's so much going on. Okay, they've got a hind foot. Okay, well, let's see. I could do an Evans. I can do a cotton. Do I need to do the cotton? Oh, okay. Can't forget about the gastroc. Okay, so, and if, number one, if you just say, I'll see you back, take some time to think about it. I need to think about it. Or send in for a second opinion is always reasonable, right? Because especially a surgery is a big deal. I see them, I kind of always joke, right? The night before surgery, I'm thinking like, what do I have tomorrow again? Like, I don't even know. What do I have? What's on my schedule? And the patient's at home thinking, I'm having surgery tomorrow. So I've got family coming into town. This is a big deal. Right. I'm not saying I don't take it seriously, because I do, but that you have a very different interpretation of that surgical day and the surgical recovery process, that it is such an important event in their life. And for you, you want to do a great job for them, that it's not unreasonable to take some time, think about it, consider all the options, and even get a second opinion and make sure that you're on the right path. Now, don't send it to someone who's going to steal your patients, right? That's a good way to, rub people the wrong way. If you get,
point. One of my close friends had a PT tendon rupture and had to do basically a flat foot reconstruction not a couple of years ago, and really saw the impact on him for 6 to 12 months afterwards. And for us, it's another day in the office. For a patient, right. It's a 6 to 12 month ordeal in recovery for a lot of these reconstructive surgeries.
So I think we'll leave off there for this episode. Again, who won debate mate? Believe it or not, Leland and I actually are friends, even though we, I haven't called you dumb or stupid or anything yet. We leave the name calling out of it.
It's only episode 3 though, right? So,
well, I think the more comfortable we get, we'll get throw there down a little bit more. Especially, isn't that's kind of the insult for people who don't have a good argument? They start attacking the other person.
Yeah.
Yeah, you got a dumb haircut, by the way.
Whatever tact necessary to win, right? So that's fine.
Stick with us as we move forward with Paw Patrol. We have some really good guests coming up. I went down the hall and I pulled a really, really good guest that some people are aware of. My wife, who's a podiatrist.
Yeah, we're eager to bring her on.
I know people are probably tuning in and thinking like, where is she? I thought she was going to be the face that we saw in here, not your ugly mug. But as we move forward, we got some really good guests signed up already, and we'll continue to put those out for you. So stick with us. Signing off on Paw Patrol is Dr. Jeff Dikis.
And Dr. Leland Jaffe. Until next time.
Jeffy and Jaffe. Bye now.
Love it.